Yeah, okay. So I have got the job of comparing Dr. Prabhudesai with Pritham because I'm going to compare scleral buckle and vitrectomy, and I hope it is not penalized. Okay, so let us see what has happened. What has happened is with the surgical techniques evolving, the prognosis of rhegmatogenous retinal detachment has become better and better. But we have still not reached an agreement as to what is good, whether it's a buckle that is good or whether it is the vitrectomy that is good. But one thing is for sure, the art of scleral buckle that was being transmitted from generations down is now going down. And many a times people rather combine both these procedures like a buckle or a band with a vitrectomy to give good results. And like Dr. Prabhudesai had said, it is basically now what is happening is that scleral buckle being a difficult technique, it is not getting transmitted down or the skill transfer is not so much as much as vitrectomy. And that's why vitrectomy is becoming more preferred. It is basically because it has started evolving and it has greatly evolved from 20 gauge to 23 to 25 to 27. The wide field viewing systems has made this visualization so good and accurate that people prefer to directly see the retina rather than do an indirect ophthalmoscope and bend their backs. Like Pritham said, the better cutters and vitrectomy consoles with their duty cycles have improved the vitrectomy as an experience itself and the chances of success. Also, from the patient point of view, there is less pain immediately after the surgery, and even in the long run, we know that the buckle thing can really be painful as much as up to 6 weeks for the patient. Now, most importantly, what has happened is, but the past plan of vitrectomy has become easier to teach now. It is basically because you can see it on the monitor. You can have a 3D experience. So teaching a past plan of vitrectomy is become a more easier option for teachers as compared to teaching a scleral buckle. And we all remember from our Netrala days how much our teachers had to bend their backs literally to teach us about that. But there's a disadvantage to it also. Vitrectomy requires post-operative positioning as per the gas bubble or silicone oil. Okay, it also causes a rise in IOP and cataract, which is almost there in 80% of the people, as we know. In pseudophakic eyes, it can cause an IOL to get subluxated or decentered, and the retinal folds and PVR can occur. Remember one thing, vitrectomy is a very less forgiving surgery. If you fail in a vitrectomy, you get a very severe complication as compared to a buckle, where you might just get a retina which is not well settled, but you will not get that severe PVR, and you can always go back and settle it with a secondary vitrectomy. The other major drawback of a primary vitrectomy is that it is still associated with high rates of anatomical and functional failures. Now, that might seem surprising to most of us, but if you really look at it, there is a 100% chance of success instantly. But if you see as the honeymoon period gets over, from weeks to months, we start seeing that the same very eyes with oil or with other PVR coming in, you get late failures, and the success of a buckle always stays, but the success of a vitrectomy may not always stay. And that's why that leads to overuse of silicone oil, and that makes the surgery more expensive with PFCL oil and the newer gadgets to come in. Scleral buckle, it's an extraocular procedure like Dr. Nitin Prabhudesa said. It does not induce cataract. It's low budget, does not need tamponade, doesn't need sophistication. And now we can have a chandelier assisted scleral buckle. That will help a better visualization and more comfort of surgery. And we can teach more on a chandelier assisted scleral buckle. The only problem is it makes your globe out of shape. It can cause a muscle imbalance. It can cause a squint. It can cause diplopia. And you require a lot of skill. You need to bend your back. Basically, scleral buckle is nothing but having a good IO, and many people are not willing to do that today. Also, the use of cryo can have increased chances of PVR. But still, whatever you say, it's a better technique in younger eyes. So if you just compare both of them, you can see that the single surgery success rate is actually more in a scleral buckle as compared to a past planar vitrectomy. And this chart sort of enumerates all the positives and negatives that you can see in a scleral buckle vis-a-vis a past planar vitrectomy. Now, as we know, scleral buckle is basically indicated in a detachment which is non-complicated in a young adult with a partial detachment of one or two quadrant in a phakic eyes. detachment with minimal vitreous changes, and detachment with anterior retinal breaks or dialysis. Whereas vitrectomy will be definitely there in a thin sclera, GRT, multiple tears, vitreous tractions, vitreous opacities, hemorrhage, and recurrent retinal detachments, associated pathologies like macro, etc. So, like vitrectomy can be done in all the indications, scleral buckle can be done only in these indications and gets ruled out the minute you go there. Now, remember the studies that have been done to compare pars plana vitrectomy and scleral buckle are basically done on these indications and not on these. So, when you keep that in mind, you will be not surprised to know that the visual outcomes are comparable in both. There is really not much significant or anatomical or functional difference between scleral buckle versus PPV. But Park et al. Have reported that PPV might show better outcomes as compared to scleral buckle in older phakic patients, and that might be because already you can have the PVD that is there, like Pritam had mentioned. So if the PVD is already there, you're not going to induce a PVD, you're already going to dissect the vitreous better. The PPV might give you a better sort of success. In pseudophakic eyes with uncomplicated RT, the initial and final anatomical outcomes have been reported to be better with PPV alone or PPV combined with scleral buckle. So these are the few of the surgeries. There have been a lot of surgeries, the studies that are done. But one of the main study was the SPR study group, which studied both the scleral buckle versus PPV. And you can see the anatomical and the functional results in both. But if you see in phakic eyes, the scleral buckle, the single surgical success rate is 63%, and PPV is also 63%. But when it comes to pseudophakic eyes, PPV gives you a much better success rate as compared to a scleral buckle. So in conclusion, the controversy still continues. We can go on and on debating which is good, which is bad. I think it is basically more with what the surgeon is comfortable for that particular indications. It has to be individualized as per the surgeon's preference and comfort with a particular technique. There's no point trying a technique which you're not comfortable with. But scleral buckle, although we might call it as an old technique, it still holds good and can give excellent results if it's performed well. And if you really follow the old traditional Netrale style, I'm telling you, scleral buckle can definitely give fantastic results. And it will be definitely advisable for young retina surgeons to acquire this skill set. Just to finish off, I still prefer a combination of both. You can do a buckle to the areas. This is the coloboma case in which I put an encerclage plus a buckle in the superotemporal area. And what happens is it gives you a fantastic visualization of the breaks. It gives you a good support of the breaks. It supports even missed breaks. It even assists you in doing a good endo laser in the end, and you really don't need to put oil for a long-term visual gains. Thank you. Thank you very much.